Within this section, what we're going to talk about are some of the older methodologies for fecal microbiota transplantation, where you as a patient will gain insight into the techniques that have now paved the way for pharmaceutical companies to produce products and put them through phase 2 and phase 3 clinical trials, hopefully ultimately gaining clearance by the FDA as products that can be used more widely. So how do we do it? And hopefully in the past we'll look back and say, how did we do this? But ultimately right now, this is a technique that's being used fairly widely by providers who don't exactly have access to the pharmaceutical trials that I alluded to before. The way that we do fecal transplants is by initially identifying a donor. And that donor is usually either a friend or a relative of the patient in need. Occasionally, it's a stranger who's willing to donate their stool. The initial assessment of an individual who might potentially donate is taking them through a medical history, asking them about diseases that we believe might be transcribed through a fecal transplant. And these include rheumatologic diseases, functional diseases such as fibromyalgia or irritable bowel syndrome, in addition to cardiovascular disease, obesity, whether an individual has recently been exposed to antibiotics within the previous 3 months. If the potential donor passes this initial screen, they are then taken through a universal blood donor questionnaire. And this is a broad overview of assessing the risk of transcription of various infections through the microbiome. If the individual who's a potential donor passes that phase, they will then have their blood work and their stool screened for various infections. The blood work is screened for hepatitis A, B, C, HIV, as well as syphilis. The stool studies screen for C. difficile infection, stool culture, stool ova and parasite, and other infections including Giardia, Cryptosporidia, Isospora, Cyclospora. If the donor is clear of all of those things, then they have the privilege of coming the day of the procedure to donate the stool. Within our fecal transplant system, we use fresh stool donated on site the day of the procedure. The reason for that is that there have been reports on a national and international scale of individuals bringing in not the donor feces, and sometimes, as gross as it may sound, non-human feces. In order to protect the individuals receiving the fecal transplant, we have the donors donate on site. And what we do is we give them a Dulcolax in the morning of the procedure. Once they receive the Dulcolax, usually they move their bowels within about 1 to 2 hours. That stool specimen is stored at room temperature, and ultimately when the procedure is ready, it is brought into the procedure room. At that time, we take about 100 grams of stool, we mix it with 500 milliliters of normal saline, and blenderize it. It's blenderized for approximately 3 to 4 minutes, and then there is a sieve process where we remove the fibrous contents of the liquid, isolating the bacteria and the other elements from the stool that we are focused on most that will help the recipient the most. This liquid matter is then drawn up into 5 or 6 60 milliliter syringes. At that point, a colonoscopy is performed on the recipient, and during that colonoscopy, the scope is passed to the end of the colon and then into the last portion of the small bowel. Within the last portion of the small bowel, 1 syringe or 60 milliliters is usually instilled. Then in the end of the colon, or the tip of the colon, sometimes referred to as the cecum, 60 milliliters or 120 milliliters is placed. In the ascending colon, just above the tip of the colon, another 60 milliliters is placed, and then approximately 60 milliliters is placed in the transverse colon. Typically before the colonoscopy, Imodium is given as an antidiarrheal to the recipient. That will hopefully allow the recipient to hold the matter that was put into their bowel longer than if they didn't receive this. At the end of the colonoscopy, the recipient is asked to hold the air and the fluid as long as possible. Typically, after the colonoscopy, patients will receive a call 1 day, 3 days, and 7 days just to make sure that they're feeling well and everything is going as smoothly as possible. After 30 days, the patient will have a follow-up office visit. If they have a recurrence during that time frame, a repeat fecal transplant is performed most commonly with the same donor stool as the previous transplant, and that will push the ability to eradicate C. difficile up to the quoted 92% that is seen across multiple trials. As we can see, the fecal transplant methodology that I presented here is fairly rudimentary, but is incredibly effective, and it has really paved the way for pharmaceutical companies to develop products in enema form or capsule form that can be used and are in phase 2 and phase 3 trials now. But even today, in 2019, this methodology is being employed because not everybody and every individual is able to be entered into a pharmaceutical trial because there's inclusion and exclusion criteria, and many patients unfortunately are excluded from clinical trials. Therefore, this methodology can certainly be used in those excluded from the clinical trials to allow those individuals access to this very effective therapy. Given the rudimentary nature of this therapy, though, it is our goal as practitioners to hopefully step away from these methodologies in the future with more clean, safer methods that have FDA approval from pharmaceutical companies.